So can we start? Should I?
Let me introduce you, Dr. Menegozzo.
Okay, thank you.
Okay, so today I have the pleasure of introducing to you Dr. Carlos Menegozzo, Director of Surgical Point of Care, Trauma and General Surgery, Department of São Paulo University, Brazil. Be welcome, Dr. Menegozzo.
Thank you very much. So hi everyone, good morning and good afternoon to the people that's in a different time zone. I'm going to show you a case that we had in the University of São Paulo, and as usual, I'm going to put this in an interactive way. So if you guys are able to join me in the interactive discussion, just point your cameras to the QR code that is in the lower left of your screen, and you will be directed to a web page where you can put PTS 23 in the room name, and you should be seeing a question with an open response, an open answer that you can put in and you can type there. So if you're listening, if you are seeing that, that's perfect. If you are not, just tell me, and I can arrange these to make sure you're going to be able to participate in the interactive discussion. So this is a very interesting case. I'm going to start here. So the patient is a 44-year-old male. He was injured with 2 stab wounds, one to the left flank and another one to the left shoulder, as you guys can see in the illustration to the right. Unfortunately, we didn't have any vital signs in the scene. This patient came to the hospital. He was brought by a third party. No doctors involved in the first assessment at the scene, and the transport time they told us that was 30 minutes. So this illustrates where the injuries of where the stab wounds were located. So you can see the left upper shoulder on the posterior aspect, and also on the left flank, where you can see the other red circle. So the primary survey inside the hospital, the patient had clear airways. He had diminished breath sounds on the left lower base, and also he was saturating 100%. He was using a non-rebreathable mask. On his vital signs continuing, he had 86 BPM for a heart rate, and he was stable. He had adequate perfusion, no signs of external bleeding whatsoever. He had a Glasgow Coma scale of 15, and the 2 stab wound lacerations that I just showed you, we could also see it in the first assessment. So this is actually the pictures. You can see on the right side that you have the upper stab wound, which you could see some of the subcutaneous tissue. There was no bleeding, and also there was this laceration, this lower laceration on the left flank, a little bit posteriorly, where you could see some of the subcutaneous tissue, and also something that resembled intra-abdominal fat tissue from the radial omentum probably, and also a little bit of oozing here on the left side, but not anything that's really voluptuous, just some signs of small bleeding. And on the secondary survey, he had a diffuse abdominal pain with rebound tenderness, and this was his arterial gas examination. So lactate level was 29, and the base deficit of 4. The rest is almost perfectly almost normal. So this is the first question. What would be your main concerns in this situation now? And I'm going to open the discussion for the panelists as well. And if you could put your answers here in the Socrates Students app, that would be great, because we can share this with everyone afterwards. You don't have to identify yourself; just share your thoughts in the answer part, and we can share this with everyone afterwards.
Thank you, Doctor. Dr. Intl, would you like to have any comments?
Certainly, I don't have enough bandwidth to both see the screen and do the Socrates, so I haven't been able to vote for that. But and I don't know what the options are. But in any event, this patient, he's stable clinically, and you did an initial exam, and because he's stable, he can go to CT scan. But before that, I would still do an EFAST, looking in particular at the left lung to be sure that there's no pneumothorax and there's no hemothorax. And I would just do a full EFAST exam, and then also look at the including the abdomen. If that were coming so far posteriorly on the left side, I suppose it's possible. It could have been a very long knife, but I'm just looking at a photograph, and you're there seeing it live. So if it really looks like omentum, and you really think it's omentum, that's quite remarkable. But and I would certainly do an EFAST to see if there's anything obvious, but with the patient being stable, I would then proceed shortly after that, as soon as possible, to do a chest and abdomen CT scan.
Thank you.
Thank you. And just to make sure we don't have any options in this first question, it's an open question, so feel free to comment on any concerns about the situation.
Mm-hmm. Thank you, Dr. Antrak. Dr. Supa, would you like to make any comment, please?
Yes, thank you, Patricia. In this patient, I think he has peritonitis on examination, and he has evisceration of abdominal fat through the back wound. I think this is enough to take him to the OR for exploratory laparotomy. And for the left chest, I think I would put in the left chest tube, because he had decreased breath sound on the left side. But chest X-ray before putting in the chest tube is okay with me. But I think he should be sent to the OR for ELAP. Thank you very much.
Thank you, Dr. Supa. Dr. Ramos, any comment?
Yeah, I agree. I would do an EFAST, and I'm worried with pneumothorax and with any lesions of the left kidney or the colon. So after the EFAST, take him to the CT.
Thank you, Dr. Ramos. Dr. Supa, we can't hear you. Yes.
I'm talking to my residents, sorry.
Okay, no problem.
No problem. So these are the answers that we got from some of the other participants. So the main concerns would be peritonitis and intra-abdominal injury. I think that's a fair thinking of the situation. Left pneumothorax and left hemothorax as well. We were also concerned about that. And about the intrathoracic vascular injury, we were a little bit less concerned because the first stab, the upper stab wound, didn't seem initially to have penetrated the thoracic cavity, and the left lower flank injury would be really a little bit far from the other injuries. But it's very important to remember that you can also have injuries to great vessels or even to the heart whenever you have left thoracoabdominal injuries and also left thoracic injuries. So this was one of the concerns, of course, and we started to think about what would be our next move here. So some of you guys just mentioned about making the EFAST, and some of the other participants about taking the patient to the OR, and this would be the second question. So if you guys want to vote quickly in the app as this time again. So what would be the next step in terms of the next move that we would be doing? So would this guy need some blood transfusion or anything related to resuscitation before doing anything? Would you guys put the left thoracostomy before any image test, or would you wait for the EFAST? Or would you take this patient directly to the OR instead of doing CT scan or EFASTs? I don't know if any of the panelists want to comment a little bit more in how how would you manage in your service this patient in this situation?
So, Dr. Supa, any comment?
I think EFAST is okay to check for pneumo hemothorax and pericardial blood. He doesn't need blood transfusion at this moment, but you should do the matching grouping and get some blood to the OR. I agree with putting in left chest tube because he has decreased breath sound. And I think the only imaging study that I would obtain at this point is a chest X-ray, maybe after chest tube insertion, and I would take him to the OR for exploratory laparotomy. Thank you.
Thank you, Dr. Supa. Dr. Antrak, any comment?
Yeah, so yes, I think EFAST is really part of the physical exam, and it's so quick, it's so fast that you get right away. You get the information: does the patient need a procedure, and what body cavity? And often it's negative. But if you have a patient who is normotensive with and not tachycardic, then an EFAST, I think. It's very helpful if a patient is hypotensive and you get a negative EFAST. Well, then it's still problematic. But I think that Dr. Supa's approach is an excellent one, because it looks like the patient's going to need a laparotomy, and if you're going to take him to the operating room for a laparotomy, it's always safer to have a chest tube on the left side where he has a stab wound, and the left flank wound could have gone up above the diaphragm or below. So. But I think that's all. It's a classical approach, and it's always an excellent strategy, simply to avoid having to deal with a patient suffering a pneumothorax or a tension pneumothorax or a hemopneumothorax without a chest tube while you're exploring the abdomen. I think that's all reasonable. But if the patient is stable and you have access, I think you just have more information about subtle injuries or injuries that you might not expect, or compound injuries. If you do have a CT scan, if you have the time to do it and the patient is looking good, it'll certainly help you avoid to miss anything more subtle. But either approach, I think Dr. Supa's approach is perfectly a perfectly good one.
Thank you, Dr. Antrak. Dr. Collet, can you hear me? Dr. Collet?
Yes, I am here. I can.
Do you have any comment?
No, I believe the great problem is a case depends where you are. If you are in a small hospital, you don't have any images or some things, you can go to laparotomy and put a chest tube, as Dr. Supa says. If you go, I think it is one great problem is all people believe that EFAST is very, very safely. It can be diagnose everything. No, it's not true. So in this situation, sometimes you have a simple X-ray may be important to do in this in this moment. X-ray of the chest X-ray, you can see if there is some hemothorax or pneumothorax, and sometimes you can put a chest tube more easy. Don't need a CT. I believe this in hospitals, clinics, you go to EFAST, you can see the problem, and then go to the CT, and then you can show what you can do with the patient. I know the patients need to go to surgery. Well, what I can do in the surgery, I don't know. I can use laparoscopy. I can use sometimes angio embolization. Sometimes it only depends on the injuries. So today, where you are, they can define what you can do and can choose. So I think it's very important to know this, because we are talking people working in several different places. So it's very important. That's it. Thank you.
Thank you, Dr. Collet. Dr. Ramos, do you have any comment?
Around hospital, since the CT is nearby, it's very near the trauma bay, we will take him to the CT. And since Dr. Carlos mentioned that it doesn't look like the upper stab wound entered the thorax, we wouldn't put a chest tube immediately. We would first take him to the CT and then see how it goes. Thank you.
Thank you, Dr. Ramos. Dr. Carlos?
Excellent,
Menegozzo?
perfect. Yeah, thank you. So the people from in the ER, they perform the EFAST. Unfortunately, I don't have the images to show you, but on the record, it was reading that there was no pericardial effusion. There was a left hemothorax. They didn't see a pneumothorax, and they were a little bit in doubt about having fluid in the abdomen. So the patient in this time, the patient had a massive hematemesis in the emergency room, the trauma bay. The guys from the ER, they were concerned about having a airway protected, so they performed an intubation and went to the CT afterwards because they were concerned about what other injuries might there be. And they were all already thinking about the indication for surgery because of having this this segment of great omentum coming outside the injury. So I'm going to show you the CT scan. This is the axial CT scan. You can see the hemothorax over here, and then you can see the stomach. And here you have the spleen. There's an injury to the spleen and some fluid around the spleen as well. But and some fluid around the liver, and no other any other injuries you could not see in the CT scan in the lower part of the peritoneal cavity. So I'm going to show you again the fluid around the spleen here, the fluid around the liver over here, and then you can see there's the splenic laceration here in this area where you can see a hypodensity image, and you can see it's very, very close to the stomach. So there was concern about having also injuries to the stomach and injuries to the colon, to the left colon, and this was really concerned for the team. So this is the other image. So it's a coronal view. You can see the stomach here, some fluid over here, and some fluid over around the liver as well, and you can see the splenic laceration I'm going to show you. So it's over here, and as you can see in the first images, it was really, really close again to the fundus of the stomach. So there's a little bit concerned. Now it's obvious that the stab wound was penetrated the intra-abdominal cavity, and so you have these other concerns about the injuries. So what would you do in this situation now? So after seeing the images and seeing the patient how he was going, what would you do now? Would you go for a non-operative management, laparoscopy, laparotomy, thoracoscopy, or thoracotomy, and maybe a combination of both? So I'm going to open for discussion, and you guys can vote in the app once more.
Okay. Thank you, Dr. Menegozzo. Dr. Antrak, would you like to share your experience?
Yeah, certainly. So just one quick question. After the massive hematemesis, you didn't mention, but I assume because you didn't mention his vital signs were still stable. He went to CT, so he didn't get tachycardic and hypotensive.
Yeah, I'm sorry. So
yeah,
right? So yeah, exactly. So
yeah,
there was no really big changes in the hemodynamics.
Right. Okay. So you know, I wouldn't. I can't imagine. Must have been stabbed with a very long knife. I don't know if you know what the weapon was, if you've seen the weapon, but and you can see on the CT scan it went straight between the ribs and through the spleen and into the stomach, you know, along the greater curve most likely, and then he bled from the spleen into the stomach, and then he had hematemesis. So I wouldn't. I think that's really. I can't imagine non-operative management. So I wouldn't do that, and I would go. And in fact, depending on, as Dr. Collet said, if you were in a remote hospital and this patient came, Dr. Supa's approach would have been excellent. You do a chest X-ray or not do it, and then to the ELR and then you would have found the wound, and that would have worked fine. And if you're in a well-equipped hospital, I think you have all the, you have the time, as otherwise stable patient. I think it's reasonable to do a CT scan simply because you go in knowing more precisely what you have. And if the pancreas were injured, and you might see it on the CT scan, and you should be able to see on exploration, but it would help you avoid missing the fast exam. I agree with Dr. Tele. Sometimes it doesn't, it's a negative fast or EFAST with an injury. But if an EFAST is positive, then it's a true positive. It's very specific exam, and it's so easy to do that I think it's really part of the evaluation. So in this case, I would go right to the operator, the chest tube, and then to the operator and do a laparotomy, take out the spleen, or repair the spleen, and then repair the stomach, and then do a full exploration. Also look carefully at the diaphragm, because it's I think more likely that it was the left flank wound that gave him the hemothorax. He likely has a stab wound through the diaphragm that needs to be repaired.
Thank you, Dr. Antrak. Dr. Tele, would you like to make any comment?
Yes, I agree that the patients in these situations have injury of the stomach and have great hematomas by the stomach. So in this situation, I think the patients need to go to OR. You can start the surgery, if you can believe, can start with a laparoscopy, and if you have training and you have the equipment, and then you can try to find the injuries and can make a splenectomy by laparoscopy. It can suture the stomach. But it's clear all people in these situations need to go to OR. The OR may be a laparotomy, there's classic laparotomy, and then you can see injuries of the spleen and the stomach. And sometimes in these situations, you can have injuries of diaphragm, and diaphragm injuries can be treated too. So in these situations, you have to show if they have any injuries of diaphragm and can treat it. Sometimes the injuries of the chest or the blood come from the chest, come from the abdomen for an injury of the diaphragm. They can aspirate the blood for the chest. So it's very important to do this exploration. So we can do by laparoscopy if you have training and you have the equipment, it start. But usually when you start a laparoscopy in trauma, you have all the equipment for laparotomy to conversion immediately. So you don't have to, if you start, you have the equipment as soon as possible in the OR. So you can start with laparoscopy. If you have any problem, you can convert to a conventional surgery. That's the way I think.
Thank you, Dr. Tele. Dr. Supa, any comment, please?
I agree with taking the patient to the OR and perform laparotomy. And my operative approach would be exactly like Dr. Tele and Dr. Untrak mentioned. And if you are an expert at laparoscopy, like Dr. Tele, you can try laparoscopy first. But I think it would be difficult in this patient because the injury is quite posterior. You're gonna have to explore the retroperitoneal area, and you have to enter the laser set and do the splenectomy, which I think it may be difficult to do it laparoscopically. Thank you.
Thank you, Dr. Supa. Dr. Ramos, any comment?
Nothing different from what everybody just said. Just put a chest tube and take it to the OR, and my concern is still the stomach and the left colon. Thank you.
Thank you, Dr. Ramos. Dr. Menegozzo, your turn.
So I think that Dr. Untrak has raised his hand. I'm not sure if.
Yeah, I did. I just wanted to add a quick comment. I would do it laparoscopically because you know, I'm not of the caliber of Dr. Clay, but I'm sure he could do it laparoscopically, and you would use the kind of dissection that you do when you do a lap Nissen. You take down the short gastrics, you can staple it. I used to do it with a stapler. You can do it with a harmonic scalpel, whatever. And then you would see the greater curve of the stomach, and the fundus would be all mobile. And then you could, I guess, repair a stab wound to the stomach with a stapler, then remove the spleen. Then you can look at the diaphragm and see that rather well. And then if you're good, you just suture it up with, I used to use the endo stitch, or you can, however you want to do it. So, you know, I think someone like Dr. Calais could confidently do it. And you know, 20 years from now, it's probably going to be the standard of care in trauma centers to do it that way. But I would be it would be a little daunting for me to take a seriously injured patient and do it that way.
Thank you, Dr. Antrak.
Yeah, thanks a lot. So very, very interesting comments, and also coming in from the rest of the participants. Most of them voted for laparotomy, and some of them voted for thoracoscopy. So that was really interesting discussion and a very intriguing situation, because you have a lot of different approaches for these patients. So in this situation particularly, we opted for a laparoscopic approach initially. I wasn't involved in this surgery, and neither Dr. Collet, but the rest of the team was involved, and this was the position that we put the patient in the OR. So you can see we only have one of the screens. We don't have both, but we put the screen here in the upper left area, and the surgeon could operate between the legs or on the right side of the patient. And this was the ports that the team used. So initially they used one 10 millimeter in the umbilicus and two 5 millimeters. This is how we usually perform the diagnostic laparoscopy in our institution. And during the surgery, they opted to use a 12 millimeter for one of the instruments, and also another 10 millimeter port in the left flank because of the situation that they encountered, and I'm going to explain this a little bit more in the end of the presentation. So I'm going to show you first what they found, and I edited this video for the sake of this meeting. So I'm going to show you what they found, and then we're going to have a little bit of discussion what to do, and then I'm going to show you what they did in the operation. So this is the diagnostic laparoscopy. They found a little bit of blood inside the abdomen, so you can see the left lower lobe. You can see also there the left upper quadrant, so there's the blood, and you can see a little bit of the stomach, a little bit of the colon there also, and the greater omentum. And also you can see a little bit blood where we could see in the CT scan right alongside the liver. And so you can see also the hole in the stomach, and they started to manipulate it to see if the hole was a through and through injury. What was happening? They found this laceration to the lower pole of the spleen, and you can see that's almost a complete transection of the lower pole. And then they started to aspirate the blood and saw this injury in the diaphragm. And you will see that there's blood coming from this injury, and you can see that there's an arterial blood coming from the intercostal artery. So now you have this situation, and I'm going to open the discussion a little bit once again, so we can discuss this. So what would you do? Would you convert the surgery, or would you continue this laparoscopically? What would you do with the splenic injury? What would you do with the gastric injury? And what would you do with the diaphragmatic laceration, which has an arterial bleeding coming from this laceration? So it's open for the discussion.
Thank you, Dr. Menegozzo. Dr. Supa, would you like to share your experience with us?
Yes, thank you. Because he has active bleeding through the diaphragmatic hole, I think it would be good for him to do the open surgery. And Number two, we have to explore the rectoral area, like I mentioned before, and we should look into the lesser sac and look for injury at the posterior wall of the stomach. So open surgery would be better for that exploration. And if the bleeding from the chest is active, he may need also left thoracotomy. So I think I would convert to open surgery and try to deal with the bleeding first. Thank you.
Thank you, Dr. Supa. Dr. Antrak?
Yes, so having started the operation laparoscopically, it looks like there's a good team. They knew what they were doing. They basically set it up as if they were going to do a lapnicin, and if the patient remains stable, then everything is fine. The anesthesiologists are happy. I would proceed to deal with it laparoscopically. So I would sew the diaphragm first because he's actively bleeding. So put the sutures in and sew it up, get control of the bleeding. Perhaps you can. He has a chest tube or no chest tube? Does he have? You're muted. I think I read your lips. I think you said no
Sorry.
chest tube, but
yeah, exactly.
Yes.
Thank you. Sorry.
No chest tube. Okay. Well, anyway, you can aspirate the blood from the chest through the diaphragm. I would sew it up, stop that bleeding, and then, as I mentioned before, do it like a lapnicin and divide the short gastrics, mobilize the fundus of the stomach. The spleen looks like something you can repair. Actually, you can even save the spleen. He put the GI stapler through, not the vascular may be too traumatic, but either try to staple across it or put a few sutures in the lower pole, which doesn't seem to be bleeding anymore. I would take out the part that was amputated, the very lower pole. And then once you've mobilized the fundus, you can explore the lesser sac. You can look at the pancreas, look at the posterior wall of the stomach, actually get a very, very good view using an angled laparoscope. At the same time, you can see the pancreas and mobilize, if you need, you can mobilize the splenic flexure and get a good look at the colon, and then you're done. So, and then afterwards you can do CT with oral contrast and just be sure you have missed. Having really set up excellently and made the findings, I would try to complete this laparoscopically, and I know Dr. Collet would certainly. I don't want to speak for him, but having attended so many of his presentations, he would probably finish the operation laparoscopically, and you probably did too. And if there's any doubt about the chest, certainly I put a chest tube and thoracoscope in to have a look above the diaphragm, but I think it's going to be okay in the chest.
Thank you, Dr. Antrak. Dr. Collet, any comment?
Yeah. Yes, if you have to control the TV hemorrhage can come from for the intercostal or some vessels in the chest. So at the moment you can try to clip or to ligate this vessel. The stomach is open. You can, of course, you have to go to see the back portions of the stomach. So if you can control the hemorrhage, then you can go to see all the parts of the stomach, can see the cavidad of the peoplons, see the pancreas, and it by laparoscopy. There is no problem. The great problem at this moment is how to control this hemorrhage. You can put a clip and try to clip the intercostal or the vessels near the diaphragm that is active blending. So what to do with the spleen after you can control? If you cannot convert, it's possible to control the hemorrhage with laparoscopy. You can make what to do with the spleen. You have a polar injury of the spleen. In open surgery, if you can do, you can make only a segmental injury of the spleen and take a part of this. I don't know if it's possible in the laparoscopy. Sometimes you can clip this or can suture the spleen with laparoscopy. So, but if they can be stable, no blending, you can put some adhesives or something that you can control the hemorrhage and can suture the stomach and suture the diaphragm down. Okay, I think it's possible to do with laparoscopy. There is a problem, but you have first to control the hemorrhage can come from the intercostal or some another vessels in the chest. That's the first problem. If it's not possible, of course you have to convert it. And one problem, when you have a combined injury of the diaphragm and the bowel or stomach, you have to clean the pleural cavity. You have wash out the pleural cavity. Sometimes you have problem if you don't do this. Maybe emphysema comes later. So that's it.
Perfect.
Thank you, Dr. Cole. And Dr. Ramos, do you have any comment?
Yeah, Dr. Cole just said exactly the thing I was thinking about, to wash the thorax through the abdomen, and we would open it up. Just suture the gastric injury and do everything that everybody said. But this splenic injury, we would finish the segmental loop, the injury already started, but we would suture it with pledgets. And that's it. We don't have staples for that. Thank you.
Thank you, Dr. Ramos. Dr. Menegozzo?
Yeah, thank you. Perfect. So that's very close to what everyone was thinking as well here in the discussion. So we did exactly what you all said. So the idea of the team was trying to control the hemorrhage coming from the the intercostal artery, and they did it with clips. So it was successful. They proceeded laparoscopically the rest of the procedure. So here's the opening of the back of the stomach. You can see that there's no injury to the posterior wall of the stomach. So the team was satisfied with that. And the idea and the option was to do a full splenectomy. So the way we do this in our institution, we do a lateral dissection of the spleen, and then we pass an instrument under the spleen to make sure we are having control of the hilum. And next, they opted to use a stapler. You can use a stapler or a clip or a hemolox. You can do this any way you want, but the stapler really is quicker in terms of controlling the hilum, getting the splenectomy completed. So they used a vascular unit for the stapler. So the splenectomy was completed, and they also you could always suture the gastric wall injury. They opted to use another stapler in this injury, so they did a wedge gastrectomy to make sure they are completing this part of the procedure. And now they started to explore the rest of the cavity. So they ran the bowel to make sure there was no injuries to the small bowel or to the large bowel as well. And I'm going to show you in more details this in the final of the meeting. So this is the diaphragmatic tear. The team also wanted to explore the cavity, as you all said. So they used the diaphragmatic laceration to perform a transdiaphragmatic thoracoscopy. And here you can see the washout of the pleural cavity. There was no injury to the lungs, and there was no injuries to the medial aspect of the thoracic cavity. It was only a lateral injury. So it was only the hemothorax, and they thought that the blood was coming exactly from the belly to the thorax. So they just washed out the entire cavity, and they put a left chest drain under direct visualization of the drain. And next they started they opted to put some sutures in the diaphragmatic laceration. And the problem is that you're going to see here is when they opened the medial aspect, there was no, the problem is that there's escaping of the gas of the pneumoperitoneum. So they were having a little bit of difficult to do this. You have a lot of other options to do, but the team decided to use some titanium clips to make sure that they're going that they could close a little bit the diaphragmatic laceration, and then make sure that the gas was not going to escape anymore to the thoracic cavity, and the drain was already there. So you can also clamp the drain for a little bit to make sure you can put the sutures, but you need to close the defect. So the idea was to put some clips, and now they can perform a continuous suturing of the diaphragm in a continuous fashion and more safely. And this is the final aspect of the suture. You can see the clips and the suture there. So they extracted the specimen in the bag, and also in the final aspect of the procedure, they put a drain in posteriorly to the gastric wall to make sure you would have any leaks or any pancreatic fistulas. So this is where they put the drain, and so the procedure was ended this way. So what they did was laparoscopic splenectomy, a wedge gastrectomy, the thoracoscopy to clean the thoracic cavity. So as you said, it's very it's a very complicated situation if you have a chemical pleuritis, for example, from bowel contents, the chest drainage, and also the diaphragmatic suture. This is the post-operative X-ray. You can see that the chest tube is really well placed here, coming upward, and it's a satisfactory position. And the summary of the rest of the case: so the patient was extubated in the first post-operative day. The vasoactive ducts were weaned off in the second. He got oral intake and discharged from ICU in the fourth, and the chest drain was removed in the seventh PO, in the seventh post-operative day. He was discharged, and in the clinic, they took the drain out, and the drain was exteriorized from the 10mm port that they put during the surgery. So you can see that this is the final aspect of the patient, and the drain was removed in this occasion. And this is a chest X-ray in the clinic, almost a month after the surgery. You can see that there are no other injuries, and patient went well in this situation. So I just wanted to share with you some learning points, and I'm going to open for discussion afterwards for the panelists as well. So I wanted to share three main points of this case that I thought was really interesting. So the first is the laparoscopic approach for thoracoabdominal injuries. I showed this article in another situation. This is an article from our institution. You can see that Dr. Collet is also one of the co-authors of this study, where we managed 32 patients with laparoscopy. And the reason I'm putting this is to show you that how was in our cohort, how were the associated injuries. So you can see that there are a lot of associated injuries to the liver, to the spleen, and also to the stomach and the colon. So that's why we were concerned in this case. And actually, we found injury to the stomach combined with the diaphragmatic injury. So that's the reason I'm showing this. So most of the times, and we saw another injury with the diaphragmatic injury in more than 50% of the cases, and more than almost 60% of the thoracoabdominal injuries had also diaphragmatic injury. So it's a very interesting situation, because it's better not to leave the diaphragm open, especially in the left side. So it's an interesting situation. The second learning point that I wanted to give you is how can we avoid missing injuries in trauma laparoscopy? And there's a really interesting study from the guys from South Africa. They published it in 2017, and they present us with a systematic approach to the trauma laparoscopy, and they do this sequentially. So you have the number one, they always inspect the right diaphragm and then the left diaphragm. Then you go to the anterior aspect of the gastric wall of the stomach, then the posterior aspect after opening the retroperitoneal cavity. And then you go to the duodenum, also anterior and posterior if you need to. You can see the anterior aspect of the pancreas, and then you start running the bowel all the way from the trites ligament to the colon, and then you start looking at the colon and the rectum for any injuries, and also you also have to mobilize the bowel to make sure you're not missing that. So in this article, they put this schematic to make sure we are going to follow this, and it's really easy. And also they talk about using CT scan preoperatively, which is something that we do conventionally in our institution when we want to perform a laparoscopy. So nowadays, almost 100% of the patients that are hemodynamically stable and are going to a laparoscopic procedure, we do perform the CT scan, and it's actually one of the things that we do. And also one of the things that I wanted to show you, especially regarding how to not miss injuries in trauma laparoscopy, I brought you guys another study from our institution as well, from Dr. Kawahara, and he showed how to run the bowel in patients who sustained abdominal penetrating injuries. And I brought you a video. This is not from the same case, but it's just to illustrate how we run the bowel in trauma laparoscopy. So you can grasp the small bowel, and you need to make sure you're going to look at both aspects of the small bowel. So you have to turn the bowels from side to side to make sure there are no mesenteric injuries, and also there are no injuries to the small bowel. So this is a case that I was involved in, and you can see that we can always look for the injuries in both aspects, and you need to do it to make sure you're not losing any injuries. And the last learning point that I wanted to share with you is that about non-operative management of splenic injuries. So this is not something that I particularly have experience with. Most of the times I do a splenectomy, a total splenectomy. But it's interesting that in 2017, there's this study about non-operative management of penetrating splenic trauma. So it's really interesting because it relates fairly with our case. And they showed that they included 118 patients in this study, and they showed not only they could do non-operative management, but sometimes they opted for a spleen preserving surgical therapy and not really splenectomy. And what they say in this study is that they had both stab wounds and also gunshot wounds. But the problem with gunshot wounds is that you have, most of the times you have massive injuries to the spleen, and also a lot of associated hollow viscous injuries. So that's why the rates of non-operative management and spleen preserving surgical therapy in gunshot wounds were really, really low, comparing with the stab wounds that they had a better outcome in such terms. So they advocate to some spleen preserving therapies in some patients, and this is really interesting because there is growing evidence coming from other studies that you can do not only non-operative management of the stab wounds, but also you can do, for example, splenography or just using hemostatic agents and preserving the spleen, especially due to splenic function. So the last question that I'm going to share with you guys is, after seeing all that, I was really intrigued with what to do with the spleen. Would I do a splenectomy again, or would I do something different in terms of treatments? So that's why I just wanted to tease you guys a little bit with the last question, and also ask for the final comments about the case or about the literature for the panelists. And I just wanted to thank you again for the opportunity to present. I love participating in this meeting, and I also really enjoyed because I learned a lot from you guys. Thank you very much.
Thank you, Dr. Menegozzo. It's a pleasure to have you. Dr. Collet, do you have any comments?
No, the comments that I have is very important. All the steps that Dr. Menegozzo says, how to use laparoscopy, safe use laparoscopy in trauma. I think it's very important, and I know that some years the laparoscopy will be very useful in trauma. I think the great importance of the use of laparoscopy is avoid to make big incisions and late complications of the incisions. And sometimes when you have patients who have chest injuries associated with abdominal injuries, if you avoid laparotomy, you can make more comfortable for the patient for the post-operative. So I think it's very important to know the use of laparoscopy and try to use it with safely, because some benefits for the patients. Sometimes when we elder, you can see the complication of the laparotomies and the hernias, incisional hernias that I can see, and very difficult to repair and big problem for the patients. So I think if possible, minimal invasive surgery in the trauma is one of option and maybe clear in mind of all the trauma surgeon. Thank you.
Thank you, Dr. Collet. Dr. Antrak, any comment?
Yes, so about your question, from what I saw on the video that you showed, Dr. Menegozzo, I think you could have saved the spleen because it didn't seem to be bleeding. There was just the amputated lower pole or almost amputated, and I would have removed that. And then I would have, in this case, to avoid suturing and fiddling with sutures in a fragile spleen, I would put some Surgicel and gel foam and then proceed with the rest of the case and see how it looked at the end. But I think you could have saved the spleen and still easily explore the lesser sac by dividing the short gastric vessels and free up the greater curve of the fundus and get a good view of the lesser sac and do everything that you needed to do. But it really superb case, superb job. I agree with Dr. Collet that in the future, in the not too distant future, this is going to be the standard of care for these cases. A patient that is hemodynamically stable and and you have the skill and the team and a superb job. And I guess he just spent a couple of days in the hospital and then is out and back to normal. Two questions. Firstly, how long did the operation take? Number one, compared to, it was about the same length of time, less or more than had you done the operation via laparotomy? Number two, why the pressors? You mentioned in one of the slides, you stopped the vasoactive agents the second post-op day. Why did he need them?
Yeah, so great questions. So the first one, I think that the operative procedure took almost 4 hours. And I'm sure that if you had laparotomy, I think that this situation would be resolved more briefly. I think that when you do it in laparoscopically, it takes a little bit more time. And also we have the participation of residents and all the team. So these procedures are not fully completed by the attending, for example. So most of the times this can interfere with the time. And about the vasoactive drugs, the patient needed, but a really small dose after the surgery. We thought that it would be related to the operative procedure in terms of inflammation and just a little bit of vasoactive drugs. Sometimes the teams they don't give a lot of fluids regarding the risks of coagulopathy or acidosis. So sometimes they connect a little vasoactive drugs, and it was just for I think 1 day. So they didn't give it too many credits for that because it was really low dose.
Thank you, Dr. Menegozzo. Dr. Supa, any final comments?
Yes, Patricia. Thank you very much, Dr. Carlos, for presenting this case to us. I learned a lot as usual, and I can see how far can laparoscopy do with a trauma patient, and very impressive skill you have laparoscopically. I have some question. Number one is how did you remove the spleen? Do you have to make the spleen smaller before you pull it out through the port, or you have to make a bigger incision to remove it? And the second question is how when you examine the chest through the diaphragmatic hole, do you use the longer scope to go into the chest, or you use just a regular laparoscopic camera? And that's it. Thank you very much.
Okay. Thanks a lot for the questions. They're really interesting. So regarding the spleen, after you put this in the plastic bag, you just I don't know how to say this in English, but you make like this with the spleen inside there, and you aspirate the blood. So you have like the spleen. It comes to small pieces. So then you can extract the bag without getting any spillage of the contents in the abdominal cavity. So that's why they didn't perform any larger incisions. And regarding the thoracoscopy, they didn't use any different cameras. The idea is just to put the camera on the left port, because you are closer to the diaphragmatic laceration. Because after that they put an incision in the left thorax for the abdominal, for the chest drain. So you do the incision, you put the aspiration there, you can wash and aspirate all the contents in the thoracic cavity, and then put the chest drain, and then you just move the camera back to the umbilicus.
Thank you very much.
Thank you, Dr. Super. Thank you, Dr. Menegozzo. Dr. Ramos, your final comments, please.
Hi. It was a great case. Unfortunately, we can't do that because we don't have enough material to our instrumentals are very poor. But it's amazing to see that in Brazil, we can still do something like that. So congratulations, Carlos. That was a great case. And with the splenectomy, we will do a partial splenectomy. I worked for a few years with the trauma surgeon here in Rio, Bruno Vaz. I think you know him, Carlos. And if you try to take a spleen out, he kills you. So he's always after us, taking care of us. Any type of traumas that come to the hospital, he makes the residents call him. And he always asks, what about the spleen? And he appears out of nowhere if the spleen is involved, and he doesn't let you take it all out. So in the end, I did learn how to do it. And I'm not saying that I agree with him most of the times, but in that case, I wouldn't have done it. Just partial splenectomy. Congratulations once again, and thank you very much.
Thank you, Dr. Ramos.
Yeah,
So,
and looking at hindsight, I think that probably a partial splenectomy would be enough in this case. But again, I was not involved in this situation, so I don't want to get the credits for the surgery. So it's really on the team's credit for that, because I was not directly involved in this surgery. But thanks a lot for the comments.
thank you. We share the CME code for today on the chat. Yes. And please take notes. Thank you very much, all the panelists, for the excellent comments.
Is that go very strong? Yeah, but like I was in.
Dr.
Thank you.
Antrag, Dr. Menegozzo, I fixed the Zoom registration time link. Forget. It was just a glitch with Zoom. So it's been fixed.
Thank you, Dr. Antrak, for letting us know.
Yeah.
Oh yeah,
Thank
and
you.
Dr. Antrax just told me here, the word is macerate. Perfect, Dr. Antrax. It's exactly what I was trying to remember. So you macerate the spleen to take it out in the plastic bag. Thanks a lot.
Yes, exactly. Is there an instrument that does that, or you just do it, just break it up with any old instrument?
I know that there is an instrument to do that, and I saw once guys from gynecology using that for the uterus, but normally we just use the aspirator and just you try to macerate it and pull out the contents in the aspiration.
And then Dr. Super just put in the chat morcellate. I think that's also a term to describe it. Yes.
Exactly, morcellation. Yeah, it's perfect.
Thank you, Dr. Carlos Menegozzo, for the excellent presentation. It's a pleasure to have you with us. Thank you,
Oh, it's my pleasure,
everyone.
always.
Good carnival in Brazil.
Yeah. Thank you very much, guys.
Have an
Thank you very much.
excellent week.
And happy President's Day. Happy President's Day in America.
Yes,
Yeah.
have President's Day. I am American now. I am American citizen.
Good.
Yeah.
Good.
Thank you very much.
How about, what about Dr. Maya?
No luck yet with that.
Not
Still on
yet.
a-
Yeah,
still on a
Maya, not
visa.
yet.
Still on a
Will be
visa.
soon.
Oh,
Yeah.
there you go.
Okay, thank you, Dr. Menegozzo. It was an absolutely
Thank you.
wonderful presentation. Bye. Have a good day.
Thanks a lot. Bye-bye.